The Same Qualities Foundation miaka 10 tangu kuanzishwa kwake, inakuletea msimu wa 6 wa SQF Cleft Marathon itakayofanyika Septemba mosi 2024 katika viwanja vya Sheikh Amri Abeid jijini Arusha. Mbio hizi zitahusisha kilomita 21 kwa shilingi 30,000, kilomita 10 kwa shilingi 25,000 na kilomita 5 kwa shilingi 20,000. Unaweza kujisajili kupitia lipa namba ya 54272330 jina ni The Same Qualities Foundation, au tembelea tovuti yetu kwa anwani www.samequalitiesfoundation.org. Kwa maelezo zaidi fika katika uwanja wa Sheikh Amri Abeid, hoteli ya Palace ya Arusha na SQF makao makuu yaliyopo PSSF Njiro, au tupigie simu nambari 0766 177 246 na 0769 250 101 au 0759999888. Mgeni rasmi katika mbio hizi ni Rais wa Serikali ya Mapinduzi ya Zanzibar, Mheshimiwa Dr. Hussein Ali Mwinyi. Mbio hizi zimedhaminiwa na Azam Media, watakuletea matangazo haya mbashara kabisa. SQF Cleft Marathon, hatua moja,
tabasamu moja.
Ala, naomba nikupigie baadaye kidogo. Safi, naomba nikupigie baadaye kidogo. Eh.
a lot of them have now been withdrawn from the market, and to be honest, given the strong evidence out there, they should probably never be used. And then, if we talk about how much fluid to give, so, often most of us would, start with, a 500 ml bolus of a, often a preferred balanced crystalloid solution. So here we would generally have a Hartmann's or Ringer's lactate, and just assess response on all those clinical markers that, you would assess in the patient and decide whether they need a further fluid bolus of 500 mils. And often we would give fluid boluses, reassess. And when we get up to a total of 20 or 30 mils per kilo of the total volume given, we, for the patient, we would then stop and not, particularly keep pushing fluid at that stage if we're not getting the response that we need. So essentially, it's knowing how much to give, and then, if you're not getting a response to fluid boluses, you shouldn't keep giving more. And often we wouldn't give more than 30 mils per kilo of the patient's body weight at one go anyway. Consider starting vasopressors or vasoactives early, especially if we talk about sepsis, or fluid losses. Often you can't replace it as quickly as it has been lost before. So, if your patient is shocked, hypotensive, you might want to start a vasoactive agent early while you're resuscitating the patient. And as mentioned earlier, a balanced crystalloid is preferred. You also want to obviously maintain the requirements of the patient, as well as replace the losses that may still be ongoing. So again, a little bit about the evidence on how much fluid, and obviously, as we all know, too much fluid has been harmful for patients. We know that a lot now, but they looked at what now the new standard of fluid what we would call standard care versus being a bit more restrictive on your fluid. They found that there's generally not been a difference in mortality as people would have expected. In the critically ill patient group, there's probably a slight trend in favour of the restrictive strategy. In your perioperative patient group in theatre, there's probably a slightly more harmful trend towards restrictive strategy. So essentially, I think overall, I think you just need to be very mindful. I think assess your patient's fluid state carefully, give what they need. Definitely don't overgive. Try not to undergive too much, and it's often hard to find that in-between balance, but that's really where we should aim for. And then obviously we all know the FEAST study again, so that looked at saline albumin in children, but also essentially bolus versus infusion, and obviously found that while there was no difference in mortality using saline versus albumin, if you gave boluses of fluid in children, then that was also very harmful. So if I were to just summarize, I guess, how we manage fluid in a critically ill patient, I think it's hard to really get a good assessment of the fluid state, of a patient. But I think early on it's really important to get the assessment right, and you just have to keep reassessing as you give fluid. You need to reassess: do they need more? Are they probably where they need to be? Again, like as I said, too much is harmful, too little or not enough is obviously not good for the patient either, and often it's trying to find that right balance. Choice of fluid-wise, I think obviously a balanced crystalloid is primarily preferred, except in traumatic brain injury. But, if you're using saline as your preferred resuscitation fluid, I don't think there's any harm when we're using it in the volumes that we do for simple resuscitation. I think the harm is only seen when you start to use excessive volumes of saline and your patients start to get a bit acidotic from the chloride load. And that's where, you might want to start to be mindful of ongoing saline use. Okay, I think that pretty much finishes fluid. Did anybody have any questions about fluid management just while I load up the next talk? Okay, all right, I'm going to take that as no questions. So I am just going to summarize vasoactive agents, again, because it's something we come across and use quite a lot, obviously, when we have sick patients in ICU, critically ill patients in theatre or in the emergency department. So really going to focus primarily on just vasopressors and inotropes, not so much on things that lower your blood pressure, but mainly on things that maintain blood pressure or contractility. So, why do we use vasopressors or inotropes in the first place? And often it's mainly to correct shock. And, we all know what shock is, which is essentially where you've got an inadequate delivery of oxygen to your tissues. And it could be for obviously all the common causes that we know. Now, it's really important when your patient is shocked, really, is to identify which type of shock they have, because the treatment for that is different. Hypovolemic versus cardiogenic, obviously, as you can imagine, are very different treatment arms. So you really got to diagnose the shock, and then once you know what type of shock it is, obviously you need to treat and use the appropriate agents as required. So obviously we'll talk about vasopressors. So vasopressors, essentially, they fall into pure vasoconstrictors, which are your alpha agonists like phenylephrine, metaraminol, which are purely alpha agonists. You've got your ADH receptor agonist, which is vasopressin, and then you've got, a drug called methylene blue, which really acts via nitric oxide synthase. And they're pure vasoconstrictors only. And then you've got inoconstrictors, which have both alpha and beta activity. So basically your adrenaline and noradrenaline. Now, noradrenaline is primarily an alpha agonist. It does have very small beta effects. So it's not a pure alpha agonist. It does have some minor beta effects, hence it comes under the inoconstrictor group, even though actually majority of the effects are alpha. And then we obviously all know about adrenaline. So noradrenaline, obviously, it's endogenous catecholamine, which is in our body. It's a very potent vasoconstrictor. As mentioned, very little, beta agonist activity. And, it's been well studied in the literature and almost certainly is now the preferred choice first-line agent for septic shock. So essentially a distributive shock where you've got primary vasodilatation. Noradrenaline is your first-line agent or first-line vasopressor. If I were to talk about vasopressin, essentially obviously works through an alternative pathway than your adrenoceptors. It acts on your vasopressin receptors, which are present in your vascular smooth muscle, and it's a potent vasoconstrictor. So you have to really be mindful of the dosing, and most of the dosing in the literature will not advocate going more than 2.4 units per hour. It's used as a second-line agent most commonly when you have refractory vasodilatory shock and you're on escalating noradrenaline requirements and you still can't get a good perfusion pressure. Most people would reach for vasopressin. It probably has, especially if your patient's very acidotic and your noradrenaline's starting to become your patient's less responsive to noradrenaline, then vasopressin, because it acts via different channels, different mechanisms, actually will have a greater response in your patient. But you really got to be mindful. It does really also affect your splanchnic perfusion at higher doses, and people can also get digital ischemia and lose toes and fingers because it's so potent in its vasoconstrictive property. And I guess those are probably the two most common vasopressors that are used commercially and in most institutions. Obviously, adrenaline is the other one, which I'll talk about under inotropes as well. So we talk about inotropes. Really, this is where you've got again a few more options. So you've got your inoconstrictor, which basically gives you inotropy and primarily vasoconstriction. Your beta agonists like adrenaline, and then you've got your inodilators, which have inotropy but also vasodilatation. So that has two effects on the patients. And these are your common ones, your phosphodiesterase inhibitors, which are very commonly used within the UK and some centres here in Australia. Your calcium sensitizers called levosimendan, which hasn't really gained a lot of traction because it hasn't got a lot of evidence to support benefit and it's very expensive. And then your beta agonists, dobutamine, which is probably what we would use most commonly in our centre here in Perth. And then calcium, obviously, on its own gives you inotropy. So if we talk about dobutamine, it's a synthetic catecholamine. It gives you inotropy, it gives you chronotropy, so your patients do become tachycardic. But it also affects your, your smooth muscle tone, and you get a bit of vasodilatation as well. So you end up with a increased inotropy and a vasodilatation. So often patients would need to have some noradrenaline on top to counteract some of that vasodilatation from the dobutamine. It's probably the preferred choice of inotrope in patients with cardiomyopathy in the setting of sepsis, but often, obviously, you could either use dobutamine or adrenaline, but obviously for us here, we would probably go for dobutamine as our first line. Talking about adrenaline, so obviously, again, probably a drug that's very familiar to all of you over there, endogenous catecholamine, a very potent alpha and beta agonist. So it gives you, obviously, inotropy and chronotropy. It also gives you vasoconstriction. And essentially, it increases your oxygen delivery, but it also increases your myocardial oxygen consumption. So it's not the ideal drug or inotrope for patients who've got cardiogenic shock, because it actually increases your myocardial oxygen workload. And in a patient with a failing heart, you've got to be really mindful. So while it does improve oxygen delivery, it does increase consumption as well. It does cause a transient lactic acidosis, which actually does self-correct, within the first 24 hours. So often if your patient's got a high lactate in the setting with adrenaline, it could all be attributed to the adrenaline, but you just got to be mindful. It could also be that the shock is quite bad. You can get tachyarrhythmias also with dobutamine. You quite often can get tachyarrhythmias, and then obviously your hypoglycemia is part of your fight-flight response. Talking about phosphodiesterase inhibitors, so they work via a totally different pathway that's independent from the adrenergic receptors. They basically inhibit the phosphodiesterase enzyme, which breaks down cyclic AMP. So in essence, you get increased cyclic AMP within the cells and in the cardiac myocyte, which then means that you get increased inotropy from that. And within the smooth muscle, the vascular smooth muscles, you find increased cyclic AMP causes smooth muscle relaxation, hence you get the vasodilatation as well. So that's how you get the vasodilatation effect plus the inotropy. And again, you also get chronotropy with phosphodiesterase inhibitors. They're thought to be less arrhythmogenic than your catecholamines, but obviously arrhythmias are still a common problem. And often, again, these patients on these drugs would also need a vasopressor to counteract their vasodilatation. So often you would pair milrinone or with noradrenaline. If your patients have pulmonary hypertension and right heart failure, it might be a preferred choice to use a drug like milrinone, because it actually dilates your pulmonary vasculature a bit greater than dobutamine does. So it probably gives you inotropy plus offloads a bit of the afterload of the right heart, which would be very beneficial. Talking about calcium sensitizers, levosimendan, I don't know if it's something you guys have heard of before, but let's get back up. It's a very expensive drug. It came on the market quite a few years ago. It was very popular. And essentially what it does is it basically increases your intracellular calcium. Or your intracellular response to calcium. So basically the heart is now more responsive to the calcium, and hence, again, affects the inotropy. It also opens ATP-dependent potassium channels, which then cause vasodilatation in the vascular smooth muscle, and that's why you get your vasodilatation as well. So it's good in that it doesn't increase your myocardial oxygen consumption like adrenaline does, but essentially a lot of the studies that have been conducted on the role of levosimendan in patients with a low pre-existing heart failure who undergo cardiac surgery, or patients with pre-existing or patients who get a septic cardiomyopathy, it's actually not shown to be of clinical benefit, so over alternative or standard inotropes and standard care. So I think it's a very expensive drug, but I don't know that it necessarily has got the evidence to back its role for routine use in cardiac dysfunction. So, I guess just to really talk a little bit about evidence. So there's obviously studies on noradrenaline versus vasopressin in septic shock, which has obviously not shown any difference in outcome for the patients, but so you could essentially use either one. Most will prefer noradrenaline as the first line, as I mentioned. Studies on adrenaline versus noradrenaline, again, no real difference in outcomes for the patients, but you do find the greater lactate. And noradrenaline versus dopamine, and to be honest, dopamine, again, not something that is being used very commonly anymore. It's found to be more harm from the use of dopamine with patients having greater arrhythmias. So again, it's probably fallen away from routine practice. So if I were to summarize, I guess really noradrenaline remains probably the preferred first-line agent for, I think, vasodilatory shock. Vasopressin probably your second-line agent. I think adrenaline and dobutamine are both very appropriate inotropes in sepsis with cardiomyopathy as well. But I think if you have a cardiogenic shock, then probably dobutamine or milrinone may be preferred over adrenaline purely because of the increased myocardial workload. And I think that's really just a little overview on our vasoactive agents. Any questions from anybody about what I just talked about? Just have a look on the chat. Yvonne, any questions? So you're still on there? Anybody there? Okay, well, in that case, I will end the session. And the next session, I will email the link out and the topic in a few weeks' time. Bye, everybody.
The Same Qualities Foundation miaka 10 tangu kuanzishwa kwake inakuletea msimu wa 6 wa SQF Cleft Marathon itakayofanyika Septemba mosi 2024 katika viwanja vya Sheikh Amri Abeid jijini Arusha. Mbio hizi zitahusisha kilomita 21 kwa shilingi 30,000, kilomita 10 kwa shilingi 25,000 na kilomita 5 kwa shilingi 20,000. Unaweza kujisajili kupitia lipa namba ya 54272330 jina ni The Same Qualities Foundation au tembelea tovuti yetu kwa anwani www.samequalitiesfoundation.org. Kwa maelezo zaidi fika katika uwanja wa Sheikh Amri Abeid, hoteli ya Palace ya Arusha na SQF makao makuu yaliyopo PSSF Njiro, au tupigie simu nambari 0766 177 246 na 0769 250-101 au 0759-999-888. Mgeni rasmi katika mbio hizi ni Rais wa Serikali ya Mapinduzi ya Zanzibar, Mheshimiwa Dr. Hussein Ali Mwinyi. Mbio hizi zimedhaminiwa na Azam Media, watakuletea matangazo haya mbashara kabisa. SQF Cleft Marathon, hatua moja,
tabasamu moja.